Uh, all right. Well, good afternoon, everyone. Thank you for joining us today. My name is Ogechi Emecheba, and I am the Senior Communication Specialist with AHA's Institute for Diversity and Health Equity. And so we're happy for you to join us today in this professional development series. And so the Health Equity Roundtable is essentially a group of community hospital leaders who, either by your title or by your function, you're essentially in charge of advancing health equity at your organization. And up to date, we have a little over 200 members. And so the purpose of this professional development series is, one, essentially a networking community for a lot of DE&I people who are in charge of leading health equity at their organization. Two, it's also for professional development and for moral support. And our goal for all of you is, through inspirational and learning opportunities and in-person points of connection, you can all essentially enrich your experience to being an equity leader at your organization. So the format of today's webinar is going to be about a 25-minute interview, and then they'll be followed by a 20-minute Q&A where all of you can either drop your questions in the chats or you can raise your virtual hand, and then we will just have you ask your questions. So today we're really excited to have two equity leaders essentially share the space with us today. First, we will have Joy Lewis, who is a Senior Vice President for Health Equity Strategies at AHA, and also the Executive Director at the Institute for Diversity and Health Equity. And then we'll be joined by Dr. Carl Hill, who is the Chief Diversity, Equity, and Inclusion Officer at the Alzheimer's Association. So I'm really excited for the conversation that we'll have today, and I will pass the mic to Joy. And just please, I want to make sure everyone is muted, but when we do the Q&A session, you are feel free to turn on your cameras and your mic. So Joy, you can take it from here.
Awesome. Thank you so much, Ogechi. And welcome everyone to our second virtual Health Equity Influencers Roundtable convening. I am extremely pleased to be joined by Dr. Hill. I'm going to ask Ogechi to drop his full bio in the chat, but just a few highlights from Dr. Hill's bio. As Ogechi just mentioned, he is the Chief Diversity, Equity, and Inclusion Officer for the Alzheimer's Association. What I was most struck by when I read your bio was this cross-functional partnership focus that you bring to your work. And I think that's really what we need in today's climate in order to really achieve the outcomes and the degree of transformation that we're looking for in our hospitals and health systems and in other healthcare providing organizations. So really pleased to see that emphasis. Prior to being at the Alzheimer's Association, however, Dr. Hill spent 6 years as the director of the Office of Special Populations at the National Institutes on Aging. So aging and issues related to aging and our growing senior population are not new to Dr. Hill. He's an alum of the University of Michigan School of Public Health, where he earned his PhD, and also an alum of Morehouse School of Medicine. And you've also been really instrumental in your leadership role, setting up the Center for Bioethics in Research and Healthcare at Tuskegee University. So really pleased to be in community with you today. And thanks for all your leadership to date.
Thank you, Joy. I'm excited about being here. Thanks for the invitation.
Great. And I see our numbers are climbing, folks are rolling in. So let's kick things off and just start with a little bit, as Ogechi mentioned, we've assembled leaders from across our field who are charged with and who are accountable for leading the equity agenda inside their organizations. And so you've really had an impressive career, both in the federal government, again, at NIH's National Institute on Aging, and now in your current role. Can you tell this group of leaders how you actually landed as an equity influencer yourself at the Alzheimer's Association, working on behalf of families who are coping and who are living with this very debilitating condition?
I tell you, Joanne, it was very, very intentional. I started my career in public health at the Morehouse School of Medicine public health internship program. So I was at Morehouse College, and it's how important outreach is to HBCUs. I saw a flyer, on the wall about an internship program over at Morehouse School of Medicine, where you get a chance to work with researchers at Morehouse School of Medicine and with policy people over at the Centers for Disease Control and Prevention. And it was all around, what we called at that time minority health, and so thinking about the health of the, underserved, minority populations, at that time. And so, I had a chance to to be exposed to that as a senior in college, and matriculate into the Master's in Public Health program at Morehouse School of Medicine, which had a focus on social justice and minority health, or what they called then biopsychosocial factors, which was an early way of trying to understand how social factors could link to stress and coping psychology, and how it gets under the skin to influence all sorts of biological outcomes. So just just been very intentional. Just been trained to do this work. Worked with CDC for a couple years, where I had a chance to learn about the Tuskegee syphilis study, working with Dr. Bill Jenkins and others. And there was a presidential apology from President Clinton, and a part of that apology was the development of a Centers for Bioethics and Research in Healthcare at Tuskegee syphilis study. So was a young intern, making copies and searching articles and doing all the things that interns do to help develop that center. But just had a chance to understand how injustice really relates to poor, again, minority health. And then around this time, this phrase health disparities was developing. And so, wanted to shore up some competencies, and, packed up my bag and moved to the University of Michigan. Didn't know that I needed to buy my coat in Michigan and not in Georgia. But I learned when I got there, and just had a wonderful time working with the Program for Research on Black Americans, James Jackson, the Center for Research on Ethnicity, Culture, and Health, Sherman James, just so many people that really focused in on not just disparities, but the level of analysis, right? And at that time, I was heavily focused on behavior, changing people's behavior through individual level interventions. But working at Michigan, I came to understand the importance of context and how social factors link to people's resources to make healthy decisions, or access to any healthy resources at all, or the uneven distribution of stress, like racial discrimination and racism in society, and how African Americans and Hispanic, Latinos, Native Americans, Asian Pacific Islanders bear the brunt of that kind of stress, and how it plays out in these disparities. And so, from there, started a career at the National Institute on Minority Health and Health Disparities at NIH as a project officer, really wanted to influence policy in this way. And had a wonderful time working at NIH, ended at the National Institute on Aging after about 15 years working there. And I became aware of the disparity in Alzheimer's and other dementia, and the lack of representation in clinical trials, that which really got me fired up, because I just thought that was unfair. And as many of you probably know, there's been a vast increase of resources at the federal level for Alzheimer's research, to the tune of $2.9 billion over the last 5 years or so. And so to know that the majority of this research has not included African Americans and Hispanic Latinos who are disproportionately affected, again, was a justice issue that I related to my initial work in Tuskegee with the Center for Bioethics and Research in Healthcare. So I started with the association as a VP for medical and scientific engagement, really giving presentations about Alzheimer's and dementia. I had to learn quickly about the hallmarks, amyloid, tau, neurodegeneration, PET scans, all the things that relate to cognitive impairment and Alzheimer's and various dementia. And I had a chance to lead our diversity, equity, and inclusion efforts in an interim role, and really found that role was quite enticing for me because I had a chance to include my research background, my knowledge of policy at NIH, with this strong focus on partnership, and thinking of the number of chapters that we have around the country and how we could work in communities with community-based organizations to get resources to those that are underrepresented, underserved, and disproportionately affected. And so, we've got a ways to go, got so much work to do, but we're gaining partnerships, every month, and I'm hopeful that we'll be able to use the infrastructure that we have to get the resources to the communities that need us most, Joy.
Wow, that's awesome. Thanks for walking us through your journey from the early days as an intern to where you are today. And, I think you actually elevate the message around raising your hand sometimes and just being willing to lean into opportunities as they present themselves. Because one thing leads to another. But I also heard some themes running throughout your remarks around fairness and justice and collaboration and, frankly, stamina. You're still in the game. You're still, you just said we still have a ways to go, but you are still in it. And so, and your comment about the biopsychosocial assessment really resonates with me, because in my early training in the School of Social Work at Howard University, that was, kind of the hallmark. We had to learn how to conduct biopsychosocial assessments, because at the end of the day, again, the early beginnings, the language has evolved, but it's the early beginnings of thinking about those social drivers of health.
That's right.
So spot on.
No, that's right, Joy. And at my time at NIA, I used that very lens to lead the development of the National Institute on Aging Health Disparities Research Framework, right? And so, at that time, many of my own colleagues at NIH, had the enduring question of, what is health disparities research? What does that mean? And it was, some of it was authentic, some of it was a political way of, doing nothing, and so we really walked through the process of, what rigorous health disparities research, could be, and that is the, biopsychosocial approach, really connecting, the environmental to, the biological. So in that framework, we developed 4 levels of analysis, the environmental, sociocultural, behavioral, and then biological, and really had to, really lay that out for program officials, other staff at NIA and NIH broadly. And, I think it was a worthy exercise internally, because we had a chance to educate, basic researchers or, clinical researchers who didn't really understand what we were trying to accomplish with health disparities research. And once they, kind of got on board, they were able to develop funding opportunity announcements, and we made, many awards for health disparities research. So Joy, using that lens, I had all the way in the, after my doctoral training, working at NIA, I was able to implement that to lead the development of that framework. So it was very useful.
Awesome. Thanks for that. So let's talk a little bit more about in your leadership capacity, in your role, creating policies and practices for your organization, your current organization, the Alzheimer's Association.
Yeah.
Can you reflect on what some of the challenges have been, and the flip side of that coin, what have been some of the more rewarding aspects of your work?
Yeah.
In terms of policy and really driving organizational practice change through policy?
Yeah. A really good question. What's been tough, specifically for DEI at the Alzheimer's Association is that, it's a new pillar for the organization. So we have a CEO who really champions DEI and elevated it to the level of a functional area, which was the first time for this organization, which has been around since the early 80s. So it has some history, but always had a diversity and inclusion focus, but it was kind of tucked in, but underneath programs and care and support. So given that it's relatively new, and there was a previous leader and staff in place that ran into some difficulties, there was this belief or perception that it may not work with the association. So I kind of walked into this with DEI not being as popular. And having to, really, hone in on what I think is our foundation, and that is partnerships, and so, having to define what diversity, equity, and inclusion means for Alzheimer's and other dementia, really, taking the time to go through concepts every time I, had a speaking opportunity to just slowly remind people that what we're really talking about here is those that are, underrepresented in our outreach, underserved by our resources, and that are, disproportionately affected by Alzheimer's and other dementia, and, I found that when I said it that way, whether you were on the blue or red side of the aisle, because people hear DEI and they think, blue and liberal, and some people just turn off completely because of their own politics or their own perceptions of what we're doing, but thinking about those who we don't reach and who we should be reaching, has been I think a helpful message to, kind of rally everyone around the work that we need to do, because it just doesn't make any sense from a justice perspective that, we're in communities, trying to get people resources, and we're not reaching the people who are disproportionately affected, who are most likely to have Alzheimer's or dementia. So that was an early challenge. But, a success is that I find that once you're able to, find a way to communicate to staff and volunteers in that way, people have been quite receptive, and it's intriguing to think of, how words can, really excite people or turn people off completely, and so just the term diversity, which, I have come to think of in different ways. I'm more interested in representation. Diversity is kind of an othering space for me. But when you say, are we being, representative in our work? Is everyone that needs to be at the table here? Are we thinking critically about, how to recruit and how to tailor our resources to communities so that they feel like they belong? All these, ways of going the extra step to explain to people what we're trying to accomplish. We've had some success, with our staff, really understanding that and coming to us with, ideas and opportunities and connections and partnerships which have been very stimulating and rewarding. Yeah.
That's great. That's awesome. And certainly directionally correct when you talk about really the need to provide that education. Sounds like that was baked into your early days, education and scholarship around why does this matter? What is diversity? What is equity? What is inclusion? And really the power, you speaking to the power of language. So, and we see that in our work with hospitals and health systems as well, where we talk about not waiting for folks to come to enter our space, but for hospitals to extend out into the communities around them. So there's clearly some synergy in terms of how you're thinking about the role that your folks play. So one of the things we know about the folks who occupy these roles, our chief diversity officers, our chief health equity officers, and other influencers, is that it can be a lonely place.
Yeah.
Right. You're often that lone voice in the woods trying to raise awareness and bring attention and keep the issues that are so pressing in our work front and center, and a part of whether it's the strat plan of your organization, the leadership agenda. And so one of the things we're hoping to share in community with one another is really providing support. And so if you could speak to what really sustains you in your role, and the importance of having networks that you can call on, right? Not necessarily your professional network, but other social supports that are really important to self-care as we are steeped in this work that is both, for many of us, professional and also our lived experiences, right?
Yeah, that's right. That's right, Joey. I tell you, right, you're right on with that. It's a lonely place sometimes in an organization because many times you're perceived as a watchdog, or you're the only voice in the room that's they're really advocating for those that are underserved, or forgotten, so it is tough. And in addition to that, I'm always, thinking of how I'm being perceived, right? Because, being the company guy, if you will, or, being too aligned with, everyone's momentum, doesn't put me in a good place, right? And
Right.
so, it's a number of ways that that this particular role can be lonely. I'm lucky that we have a CEO and a president who really understands the public health aspect of this, and so in turn they really get the disparities and the need for equity and intentional inclusion, right? And they understand that how in the ways that I have to work in the role may not be as how can I say this, collaborative with with all of the other chiefs, knowing that I have to take a different stance at times. But for me, it's highly personal, and so just kind of describing my journey, I was trained to do this. I didn't kind of get to this point and I said, okay, well, I want to be a chief someplace, so I'll take on DEI, that'll get me a promotion someplace. I feel like this was the logical next step for me, because from the very beginning of my first internship, it was all about, what we know now to be diversity, equity, and inclusion in a public health or health related advocacy organization, so it was what I was trained to do. And, the way that I sustain myself is to stay close to my colleagues that I have formed professional and personal relationships over the years. I'm still in touch with, my colleagues that were in the first cohort of the Masters in Public Health program at Morehouse School of Medicine. It was an intriguing time if you think of of being in a brand new MPH program at an HBCU, the
Mhm.
first time at an HBCU, right? And so it was unaccredited, and we were so enthusiastic about public health and minority health, but we had no idea, that
Wow.
we will, really disregarded by the field in so many ways. But all of us, went on to earn doctoral degrees in various areas, and we're contributing to the field. So when you go through something like that, or you have a chance to work on the development of the Center for Bioethics at Tuskegee, and it was a part of the presidential apology. I don't see this as a satellite space in the organization. I feel like it's fundamental to the mission. And if we're not considering diversity, equity, and inclusion, then there's something very huge missing from the work that we're doing, and I was trained to think that way. And so, I stay connected, and I fully believe in the fundamental nature of equity as it pertains to Alzheimer's and all other dementia.
Thank you so much for your response. I want to be cognizant of our time, because we could go on, and want to invite the audience to join us in this exchange of ideas. And I want to thank you for your insights, and really open the floor up to the folks who are on the call to
Thanks, Joy.
gain some more from your professional advice. And so if folks want to turn on their cameras, raise their hands, drop a question in the chat, I invite you to do that at this time. And I'm going to scroll and see if I see any raised hands. So while you're thinking of your questions, okay, Robert Franklin has his hand raised, so I'm going to
go ahead and say what you're going to say, Joy, and I'll say what I'll ask my question.
Oh, no, you go first.
All right. Thank you all for the time, and Dr. Hill, thank you for the vulnerable sharing. Earlier, you were talking about connecting with those, or not being able to connect with those who are afflicted by Alzheimer's and dementia, and it made me think about their family members, because oftentimes once diagnosed and once experiencing those detriments, that's not the person you actually need to reach out to. It's the family members who are considering care options and hospice and all those things. And when thinking about reaching out to those folks, there's a stigma around illness, stigma around how to connect with care. And so I wonder if you could just talk about underserved population by underserved population. How do you do that? Or what is your advice on talking about stigma when you know that person needs care and is not served for all the number of reasons you outlined?
Yeah, that's right. That's a great question, Robert. And that's from our perspective, that is the equity approach, the equity lens. So first it's acknowledging, first and foremost, Robert, that the Alzheimer's Association has not done enough in these communities, and that in order to really deliver our resources in an effective way, they have to be equitable and they have to be tailored, right? And even when we, sit behind our desk and we think that we're tailoring these resources, we may not get it right. So we've got to partner with organizations who can help us deliver these resources. So we're working with the African Methodist Episcopal Church, for example, AME Church, churches all around the country, hoping that our churches, our chapters, we have over 70 chapters, can link with churches to, best case scenario, we're able to train church staff and volunteers to deliver this information about Alzheimer's and dementia to their own congregation, to their own community. That's the best case scenario. Or they can help us by saying, hey, that's not going to fly. You got to think of it another way if you want to be effective, right? So, we work with AME, we work with the Black Nurses Association, Black Nurses Rock, my fraternity, Omega Psi Phi Fraternity Incorporated. We got the Bros going in communities. So getting that perspective, Hispanic Nurses Association, many different organizations to help us in these communities is our overall approach. And then in some instances, because African Americans, Black African Americans are 2 times more likely to develop Alzheimer's or another dementia than whites, I think we have to go the extra step. So we partnered with Garrett Davis Productions to develop a community play, a theater. So I never thought in my journey that I would be the executive producer of a play, but I had a chance to work with a playwright, and we developed this resource called Unforgettable. And it's a way for us to do just what you said, Robert, to get information to caregivers, community members about Alzheimer's and dementia, but also about the Alzheimer's Association, about our 1-800 number is free, our community forums that are free, all the things that we have that we offer for free, but to deliver that information in a culturally, I think, relevant way for some Black African American communities, and using edutainment, right? And so we debuted that in Atlanta over the summer. It's been very successful. We just had a showing of this particular play at the National Black Caucus of State Legislators in Las Vegas just last week. And so, we're using different ways to, tailor our information to get it to communities, evaluating what works well. Not everything works well. Not every partnership, really, brings, the type of impact that we like, or some partnerships take longer to develop than others, but we believe that, really leaning in and finding partners and, really engaging in the trust of, in the process of becoming trustworthy, is going to help us over the long run. There are no easy fixes with this, but certainly working with others and communities can really help us with our impact. Yeah.
Thanks, sir, and looking forward to seeing Unforgettable come all, go nationwide, so we can tap into that. Absolutely,
it will be in Los Angeles, January 14th. That's the next showing. So, tough market, LA with a community play, by the Alzheimer's Association. So we'll see how we can get people excited to come out. But it's always free of charge and just a wealth of information for communities. Yeah.
So you wear yet another hat as director producer, huh? Congrats. So we do have a question in the chat from OK, who's curious about, first thanking you for your leadership, and she wanted to hear your thoughts on where the research, the biomedical and policy ecosystems are going or can go in expanding the DEI construct to incorporate justice and anti-racism into its definition and into the frameworks, right? So if you can talk a bit more about how you map across research, biomedical, policy.
Absolutely. Well, from our perspective, I tell you what has really been helpful for us is having data in this regard. So, one of the early outcomes from being in this role was a special report that we commissioned called Race and Ethnicity and Alzheimer's in America. And we really, wanted to understand, the perceptions of Alzheimer's and dementia across various racial ethnic groups. We had a nationally representative sample of participants. And there was a specific module focused on discrimination and racism. And so, in that report, we found that, African Americans, Hispanic, Latinos perceived that they would be treated unfairly in the dementia care system because of their race or ethnicity. And then they also reported actually experiencing racism or discrimination in the dementia care system. And so, having that data, one, we released the report, and there was just a lot of press around that finding, but being able to use that data to advocate for policy change within, or more resources, or even just the work that we do in communities, and acknowledging that racism and discrimination is a factor for why people don't take us up on our free resources. Just this, the realization that when you say free, where I grew up, in College Park, right outside of Atlanta, Georgia, free always meant you had to pay something, because we just did not trust the government. We didn't trust anybody who wasn't from our community, and rightfully so. All sorts of historical atrocities that were rooted and based in interpersonal, institutional, and structural racism. So really having data and being able to locate that in the work that we do from a DEI perspective, but also I think most importantly, how racism of all forms can impact the way that we deliver on our mission. Really continues to make racism relevant for the work that we do. Yeah.
Great. You speak to the fact that data tell a story, and then we all know the power of storytelling, right?
Right. That's right.
So really important to leverage data to drive improvement.
That's right. That's right. Yeah. I've been advocating here recently for a part 2 of that special report. Because the thing that really gets me going, Joy, is the lack of representation in the clinical trials, which I think is almost criminal. Because NIH functions on taxpayer dollars.
Our dollars, correct.
Right. And to know that the studies that they fund don't include everyone, that from a justice perspective, everyone should be included. But from a disparities equity scenario, the folks that are disproportionately affected should be priority, for many of these, research areas. And so it's almost criminal to think that, our communities aren't being recruited and included, And so I've been advocating for a part 2 of that report, where instead of going to the people, us, who aren't being recruited or included, I want to understand what the issues are among the clinical trials research staff. Their perceptions of DEI. Do they think it's important? What resources do they need to do the work in a representative way? And so that's the tug of war right now that I'm currently engaged in internally, because there are other staff who don't think that is as important. It wouldn't produce any useful information. But again, that data could help us in advocating for better resources for research staff to do their work, or better accountabilities to make sure that when you submit a results from a clinical trial to FDA, representation will be a part of the review process. With no adequate representation, no approval.
That's right.
These are the realities of the situation. So absolutely, I think thinking of it in this way is so important. Yeah.
Thanks so much for your insights. I have one final closing question, besides someone in the chat who wants to know how to get their hands on a copy of that production that you mentioned.
Oh, it's coming. It's coming now. We're not going to get it on DVD yet, because we want, what I always say, bodies in seats.
Right.
And the people watch it at home on DVD, they won't come out.
Exactly.
But that is a part of the plan. And if you get a chance out, I can put the name and the link in the chat, so you can go check it out. But our next stop is Los Angeles, January 14th. If anyone is around that area.
That would be great if you can drop that information in the chat. So
Okay.
just to close out, again, this is a really targeted group of professionals who are focused on DEI. And I'm wondering if you can share with them the best professional advice you've been given over the years that you've leveraged to really get you to where you are today.
Yeah. You know, it was from my main mentor, Dr. Bill Jenkins. He passed away 2 years ago, and he was the main whistleblower at CDC on the Tuskegee syphilis study. You know, so this study was going on for 30 years, and you know how things go. You know, it's hiding in plain sight. People had come up with, you know, some rationale as to why it was just and allowable, and he really was the first person to start, you know, talking about how, you know, it violated ethics codes, and so, you know, he had a wealth of expertise, and he mentored many students, and you know, it may sound simple, you know, but his advice was, you know, don't get too comfortable. You know, and that's not from a, you know, fear of your work, but to always challenge yourself. You know, and if you're in a role and, you know, you don't feel challenged, you know, it's not rewarding, or you don't wake up every day with that fire in your belly to, you know, to make things happen, then you're too comfortable, you know, and it's time to maybe move on or to look for other challenges, you know, and that was something that he said at every stage. You know, once you get comfortable, you stop, you know, using that innovative spirit that you have. And for me, I took his advice after being at NIH for 15 years, at NIA for, you know, the National Institutional Agent for, you know, 6 years. And, you know, I was on cruise. You know, I knew the job. I had a summer program. We were training early career investigators, and, you know, we fund certain grants. And I said, it's time for me to kind of step outside of the government and take on a new challenge. And to this point, it's been quite challenging, you know, because I tell you, with the DEI work, you know, we're not gonna fix structural racism in the next couple of years. You know, we're chipping away at it, and getting resources to communities. But it has been rewarding because I believe that this is the work that I was called to do. You know,
it's the long game. It's generational work, and it sounds like if we all take that advice and build that rigor into our work lives, then we'll make the seismic shift that we're looking for. We'll start to see some of that happening. So I want to really thank you once again for spending time with us today, and hopefully the nuggets you've left will really blossom and create some further actions on the part of the folks who are fortunate enough to hear from you directly. I'm going to pivot us to some announcements. Actually, I'll take this first one. Speaking about, you know, creating these roles and the proliferation of these diversity, equity, and inclusion officer roles that we've seen in the course of, well, since George Floyd's murder, so I would say in the last 2 years or so, we're beginning to ask the question, how do you stand these roles up to be successful? Because there's just huge variation in terms of how these roles are organized inside hospitals and health systems. Some are going up through HR, some report directly to the CEO, some have a budget, some don't. So we are, AHA, the Institute, through the Institute, are partners with investigators out of Mass General Brigham, who have funding from the Commonwealth Fund to really look at this dramatic increase in the number of equity officers, and to think through what's a more systematic way to think about how these roles should be created, developed, and designed. And so there is a survey in the field for all of you to participate in. It launched in October, and we are it will remain open through Q1 of 2023. And so if you have not yet received your survey, it went to your hospital or health system CEO, who should have then handed it off to you. We're going to invite you to email directly to that address you see on the screen, surveysupport@aha.org, or call that 800 number. And we'd be happy to get you a copy of this survey, because we really do need to do our due diligence to collect the experience from the field. And with that, I want to turn it over to Ogechi.
Sorry, I thought I was not on mute. All right, so thank you so much. And I just have one final closing announcement. I wanted to put this on your radar for our Accelerating Health Equity Conference, which will take place next year, May 16th through 18th in Minneapolis. And this is our third year doing this conference, and we will be in person, so it's really exciting. And this is in partnership with AHA's Community Health Improvement. And essentially, this is for if you are a frontline leader at a hospital or a health system, if you are a public health professional, or you work in a community-based organization where essentially your goal is to improve health outcomes and you're focused on DE&I strategies and equity work, this conference is for you. So we have a lot of exciting keynote speakers, which I will announce on the next slide. So our opening keynote speaker is Isabel Wilkerson, which will take place on Tuesday, May 16th. And some of you may be familiar with her book, Cast, and her other book, The Warmth of Suns. And Isabel is a really well-known journalist and a very gifted storyteller. So she will be giving the opening keynote speech. And then on day 2, our plenary speaker is Dr. Ivor Horn, who is the Director of Health Equity and Social Determinants at Google Health. And then our day 3 closing keynote speaker is Dr. Brian Smedley, who is a co-founder and executive director for the National Collaborative for Health Equity. So we have a really good lineup there. And then our first in-person Equity Influencers Roundtable will be happening at this conference next year, for the year, I should say. So that will take place, I believe, on Wednesday, May 17th. And obviously, as the time gets closer, I will be in touch with everyone to email you some details about that. But just put it on your radar that we will have the first 2023 in-person Equity Influencers Roundtable at our conference in Minneapolis. So we hope to see everyone there. And then I think that's pretty much all. I don't have any final announcements. And once this link is ready, in about 1 to 2 business days, I will email it to everybody and also include these announcements in the email. So that is it for me. Does anyone have any final questions, concerns, thoughts, or comments? Yes, no? All right. Well, that is all. So thank you so much for everyone joining us today. And thank you, especially Dr. Carl Hill. This was a very informational webinar, and we thank you for your time. And I hope to see everyone next year in Minneapolis. So thanks, everyone. All right, bye.